at the coalface. David, thank you.
Thank you, Mr. Chairman. Good morning, ladies and gentlemen. I will declare my conflicts of interest in this talk. One is I'm a cardiac surgeon, and secondly, I was one of the guideline writers. And I have to say, cardiologists never cease to amaze me. I remember I was present when the one-year results of the Syntax trial were announced at the cardiology meetings. And the cardiologists were going around slapping each other on the back, giving each other high fives, saying, "We knew it were as good as cardiac surgery." 5 years later, we see the definitive results, and to a man, every meeting the cardiologist says, "Rubbish trial, wrong stent." So whatever we do, whatever evidence is produced, this is the type of battle we always face. Anyway, I'm now going to give you my perspective on these guidelines and what's important. And I think the first thing that Philip emphasised were they were the first joint effort. They had 25 members from 13 European countries, equally divided between non-interventional cardiologists, interventional cardiologists and surgeons. And that in itself reflects the concept and the philosophy of what they're about, the heart team. And they were extensively reviewed by external referees before publication. And they are quite an extensive set of guidelines. They have 14 chapters, 270 references, and they cover all types of management of coronary artery disease, from the stable to the acute to the emergency, and coronary artery disease either in isolation or with other conditions. And one chapter in particular which is important is that which emphasises the process for decision-making and patient information, because this had not previously been done in guidelines. We've seen this about class of recommendation levels of evidence. Class 1, do it. Class 2, think about it. And Class 3, do not do it, at the different levels of evidence. And the other thing the guidelines recognised was that evidence comes from different sources. The randomised controlled trials are unquestionably the gold standard because they eliminate bias, but they often have a number of potential weaknesses, small numbers of patients, they only include a small percentage of the eligible population, and therefore they often end up with atypical patient populations. And this is compounded by short duration of follow-up, large numbers of crossovers, and that was true of 19 of the 20 randomised trials of CABG versus PCI. Now, if you look at registries, these particularly propensity-matched registries, these often contain large numbers of patients, often in fact tens of thousands of patients, and they reflect what we do in real everyday clinical practice. Of course, their potential weakness is of confounding by biases that we may know about, and more importantly, those that we do not know about. The guidelines emphasize two situations when you can carry out myocardial revascularization. That's for prognosis and symptoms. And they emphasize that for prognosis, you can only do this if you have demonstrated ischemia. So if you haven't demonstrated ischemia, you cannot say that the operation is for prognostic reasons. Now, what's important about the guidelines, we've seen this table 9. And the important thing to take away from this is, as we practice today, 79% of all patients with 3-vessel disease have Syntax scores above 22. And they are a Class 1A indication for CABG and Class 3 for PCI. And the same relative figures account for 2/3 of patients with left main with Syntax scores above 33. Now, Philip said quite rightly, these should not be seen as some kind of victory of CABG over PCI, but used to base informed discussion with the patient. As we look, if you look at the ESC guidelines today, these guidelines have been endorsed by 31 European societies of cardiology, but only 7 cardiothoracic societies in the European Union. If you look at the guidelines and compare the indications for CABG and PCI, both according to the ESC and the ACC, what you can see is, as Philip said, they all give a Class 1C recommendation for heart team discussion. But even as you look into the 8 different anatomical patterns of disease, you can see that both ESC and ACC largely agree that CABG has a Class 1 indication for most patterns of disease. And if you look at for PCI, most of the color boxes are yellow or orange, saying that you really have to be careful using PCI in stable elective patients. The guidelines also emphasized importantly the importance of providing patient information. the importance of the multidisciplinary team. And what they said was that guidelines may be used to avoid the systematic case-by-case review of all diagnostic angiograms. So when cardiologists often say at meetings, but we don't have time to discuss every patient, you don't need to discuss every patient. If you're following guidelines, there is no need for a formal heart team meeting. But the heart team really should be reserved for those cases where you decide you're not going to follow guidelines. Now, it's quite interesting how much these guidelines have changed what we knew before. Back in 2006, I reviewed all the existing guidelines in the literature at that time, the ACC, the ESC, and the British Cardiac Society. And they all recommended basically you could use PCI for most indications for patients with 2 or 3 vessel disease, including diabetes. And all of them made the point that there was no formal need to have a surgical opinion in patients with multivessel disease. If you look at who wrote those guidelines at the time, the Americans chose 23 cardiologists and a single surgeon. The Europeans didn't like that. They weren't convinced by that, so they doubled the number of cardiologists and got rid of the surgeon. And the Brits, with their sense of fair play, brought back a surgeon. But if you actually look at what happened before the current ESC-EACTS guidelines, all the recommendations in the literature have been written by 77 cardiologists and 2 surgeons. And that's why this emphasizes the absolute importance of having balanced writing committees. So what happens if we don't have guidelines and we don't have heart teams? This is a paper from Ed Hannon published in Circulation in 2010, looking at the outcome of patients who had undergone diagnostic catheterization by a cath lab cardiologist. And what they found was that if you had a class 1 recommendation for CABG, only half of the patients actually got CABG. On the other hand, if you had a class 1 indication for PCI, 94% had PCI. And if you had equipoise, where there truly was balance between the 2 techniques, 93% of patients still had PCI. And the authors went on to point out that most of the ad hoc PCI procedures were done in those hospitals with the highest rates of interventional cardiology, and that the chance of PCI increased in hospitals where there were PCI facilities. So if we look at this as a paper, what impact have the guidelines had on British practice so far? This is a paper from Martin Yates, who's one of Marjan Jahangiri's fellows, and they looked at what was happening in St. George's Hospital before the ESC-EACTS guidelines. They looked at 197 elective PCIs for multi-vessel disease, of whom 62 patients had clear surgical disease, so about 1/3. Only 9% of these were discussed at the MDT, and 14% had ad hoc PCI. If you look at the post-ESC-EACTS guidelines, they then looked at 164 elective patients, of whom 1/4 had clear surgical disease. Only 17% of these patients with multivessel disease were discussed at the MDT, and 26% still had ad hoc PCI, suggesting that the guidelines so far are not having great impact on what's happening in practice. So why should we use guidelines in heart teams? I have no question in my mind that by doing so, it benefits the patients, it benefits the heart team, it's ethically the correct thing to do, and it's essential for the survival of our specialty, because if we don't get this right, then the next thing is the valves will begin to disappear as well. What are the problems we currently face? Well, undoubtedly, the main problem today is still the gatekeeper role of the cardiologist. And the surgeon is not a gatekeeper, because most surgeons do not primarily see the patient until that patient has been referred by another group of doctors. And there are clear conflicts of interest for the cardiologist in what they do. They may be clinical, in other words, they want to have the biggest unit, do the most cases. They may be political, again, building the largest units, but often there are direct financial conflicts of interest, and I will discuss this in one of my subsequent talks today. So what is the solution to the problems that we face just now? It is to encourage MDTs with cardiologists, but I think it should go far beyond that. I think there should be regulatory insistence of following guidelines. So I disagree with Adrian that we should just kind of use them as guidelines and nothing else. I think the evidence, and again discuss this in my next talk, is very clear that in the absence of guidelines and heart teams, the chances of patients getting the right treatment are severely diminished. So I personally believe that the people who pay for interventions should say they will not pay for any intervention that is not demonstrated and documented to have followed guidelines, or if it hasn't, there has been clear discussion by a heart team as to why we are not following guidelines. So on that point, I'm going to conclude this talk. I'd like to thank the Society for the privilege of giving this presentation and you, the audience, for your attention. Thank you.
Thank you very much. Before I think we ask Mike and David for their comments as the cardiologists in the room, I think we should pause to think of our behaviours as a group of cardiac surgeons in the early days when our behaviours were not exemplary possibly in the way that we conducted ourselves. And so don't forget how money became a focus for many of our colleagues in this country and abroad. We didn't behave necessarily professionally and ethically at those times, and we're not in a good position to stand on the high ground and say we're very well behaved and aren't the cardiologists terrible. I think David alludes to it in his first slide. The interventionists and the surgeons, we all have a conflict of interest. And I think if you understand that you're protecting your personal job, your personal throughput, your department, possibly, as David says, maybe some financial, if there's private practice, etc. involved. And it's important to recognise that conflict of interest and put the patient first. And that will break down the tribal behaviours that get in the way of progress at the moment. So I'd be interested to see what David and Mike have to say.
There's some introductory comments. Come off the fence, why don't you? It's a bit like the Leveson inquiry, this, isn't it? I suddenly got this idea that it was like Leveson sitting there saying, well, you know, we ought to regulate, well, you know, the press and such like. I think that accepting your comments about behaviour, I mean, which I think, you know, I don't know what the surgeons are up to, but I know what you're getting at. I think life has changed, and I think a number of things have caused both cardiology and cardiothoracic surgery to open up their practices and be far more transparent. And Bristol and, you know, other elements are all part of that. And I think there is an evolution going on whereby we are in this together, and those sort of turf wars and pecuniary interests are, whilst perhaps still present, I think gradually being eroded. I think the stark data that you presented about more likely to get an angioplasty if you work in an angioplasty centre, I mean, it's fair to say that that was an American practice, and I think we appreciate that North American practice has some elements in it which we would not recognise, and is far more flagrantly, if that's not too strong a word, financially based. But I mean, your point is taken, but I just think it skews the discussion for perhaps a UK audience to assume that is contemporary practice in this country.
Mike, if I could just pick you up there very briefly. I'll show you this in my next talk. The difference in the rates of elective PCI to CABG in this country have a 13-fold variation depending on what part of the country you're in. And the 13-fold difference, so the lowest ratio and the highest ratio, are in two primary care trusts that are 40 miles apart. So these enormous discrepancies in what's happening to patients very much do exist in the UK, and I'll show you that more clearly in my next talk.
Yeah, okay. But I mean, there may be many reasons for that discrepancy that aren't just geographical, quite clearly, in terms of the nature of the way the patient's presenting. But I think this is fantastic food for discussion, isn't it, David?
Is it my go? I enjoyed that. It's always, you know, provocative and entertaining and persuasive.
Thank you.
And just a couple of points from my point of view. I think it's very good. It has brought cardiologists and surgeons much more together, and it will be much better in the TAVI era as well as we work more closely. But something that the guidelines don't really cover, at least for me, is that we have this heart team and a lot of discussions are had, and often the decision is almost rubber stamped before the patient is involved at all. And that, you know, and the larger the heart team gets, the more that is the case. So often the thing that matters to the patient most is not death, MI, revascularization. It's how long will I be off work? How long will I be in hospital? How long will I have to wait for this? Can I get back to look after my disabled wife, etc., etc.? And these things are all very real aspects that don't really get covered in the guidelines, but do get covered, as Adrian would probably agree, when you actually discuss it with the patient and find out what's most important to them. So that's why they're guidelines and not protocols. And the second point I want to make is I think it is reasonable that different places take different approaches, because you'll remember the syntax bubble slide where some centres had sort of 0% mortality whether you had bypass or PCI, so, well, you can have whatever you like there because they're brilliant at it. Some centres had high bypass morbidity and mortality but low PCI, and some centres had, very good bypass and very poor quality PCI. So, you pays your money and you takes your choice. You do have to judge, and everybody knows their own unit well. There are exceptional individuals and not so exceptional individuals, and those are important to take into account as well within the context of the guidelines. So there are reasons for variation and for deviation from the guidelines, which I think are very, very reasonable.
Mm-hmm. I mean, David, you may have a very different practice from mine, but I can assure you, when I see patients in my practice who are eventually sent for bypass grafting after numerous attempts at stenting, when I say to the patient, 3 years ago, did your cardiologist tell you you would have a survival advantage with surgery? The answer every single time in my whole professional career has been no. It's never discussed. Now, you may, at least in where I operate, you may be different. You may tell patients, look, if you have cabbage, you've got a much better survival, you've got far less chance of heart attack, you're far less likely to need repeat revascularization, but the patient says, no, doc, I still want your option. Maybe that's your experience, but it's certainly not mine.
Question,
Thank you. Heyman Lacrosse from the Heart and Lung Centre in Wolverhampton. I think David is very right in saying that the proportion of patient that goes for CABG or PCI within any unit is very variable within the UK and outside the UK. And in Wolverhampton, where I work with Mike, I'll show some data later on. We've been privileged in making sure that every patient that needs a discussion is discussed before a coronary intervention. But bearing that in mind, we are now working and hoping that both the Society of Cardiac Surgery and the Society of Cardiology will come forward to recommend, again, it's recommendation, that there is a set working protocol for a heart team that not only involves the surgeon, the interventional cardiologist, but also the non-interventional cardiologist and the patient. And we had such a meeting last night. I'm very, very pleased to say that I'm hoping that in the near future we will be able to define how the heart team should be working, because it's not only a meeting, it's a meeting that needs to be supported by the trust, supported by adequate personnel to make sure that it runs well, so that everybody gets presented appropriately. So there is a fair bit of working that needs to go to make sure that there is a heart team, but also that it also functions well. And later on, I'll present what happens after the heart team.
Thank you. Professor Cole.
Can I?
Sorry,
can I just answer David, because he did leave it hanging slightly. The issue for me there is that patients rarely ask. When they have the opportunity to ask things about what the treatment is they're going to have, they rarely say, Doc, which is the thing that will make me live longest? They seem much more likely to say, how soon will I get out of hospital, etc., etc., how soon will I get back to work, all the things I said. And if they do ask anything about death or calamity, it's in the short term usually. They usually want to know, well, what's my risk with this procedure? It's really rare. I don't know if other people would agree or disagree with this, but it's quite rare for people to say, I want to know which one gives me the greatest chance of being alive in 10 years' time.
Yeah.
Can I just ask, when you get the tyres changed on your car, everyone, do you get the expensive ones that last the longest, or do you go for the least pain and get the cheaper ones? Who gets the cheaper ones? Okay, I think it's that sort of discussion.
The microphone, maybe?
There's a question at the front here.
Yes. Do you hear me?
We can hear
Yes,
you.
okay. Well, I think this team discussion is very important, and I'm sure we'll discuss that in the next session also. But I think that also the health authority should get involved, and we should be encouraged. We should get some financial incentives to discuss this within the RT, just like in oncology. I don't know how it's in the UK, but in Belgium, we have to discuss oncology patient into a multidisciplinary team. It has to be documented to the child, and it's reimbursed. Part of it is a specific code, and I think it's just right. So I mean, obviously, a patient with coronary artery disease is not a cancer patient. But to some extent, if you have diabetes, if you have extensive disease, it's very prominent. So I don't know what are your thoughts about that.
I mean, the other point I would make is in British patients, all of us know we have extremely trusting patients. So they come to you, and when you sit there, they take it for granted you're offering them the best treatment. They do not assume that you have decided that they don't want to know about survival or myocardial infarct or repeat revascularization. So when the patient sits in front of you and you say you should have PCI, the patient understands that that's the best available treatment, not that it's one option. So I think to say you would not explicitly discuss with patients survival, myocardial infarction, repeat revascularization makes a nonsense of the process.
It's a good point. Is that you can wait for the patient to ask, but you can also tell him. I mean,
Sure.
it's like when you present to someone that if you change from this butter to this margarine, you get a 35% reduction of having a heart attack. But they then tell you it's a relative risk reduction. Obviously, it's not an absolute risk reduction. If you go from 3% to 2%, they tell you it's a 33% risk reduction. And if most people just don't understand that. If you don't explain them that, they will not.
I agree, but you will also be very familiar with the concept of randomizing people into the clinical studies that are CABG versus PCI. And I can tell you that even when you've given everybody all the information, the only way to get people into these studies is to say, you're going to have surgery, or you're going in the trial. You can't have PCI, because they will choose it. They will choose it, rightly or wrongly, despite having all the information. They will choose it as the less invasive option, quicker fix. And, that demonstrates the difficulty of us as the doctors trying to make decisions on the patient's behalf based on factors which ultimately are not the ones which the patients are most interested in.
Yeah. David, you need to come and spend some time with me in Oxford. We are the biggest British recruiting centre for the EXCEL trial and the second biggest centre in the world. And of all the patients we approach, cardiologists and myself, to enter the EXCEL trial, when you explain the pros and cons of both, our acceptance rate for that trial is 90%. So the vast majority. So I actually believe that if patients are given appropriate, balanced information, they don't need to be coerced one way or another. They will make up their own mind, and they will take part in trials. So I don't know how you're explaining the trial to your patients, but I'll come and help you.
Leslie, there's a question.
Leslie Hamilton, Newcastle. If I could just pick up David, if I understood you correctly, you were saying that you're aware of units or individuals, surgeons and cardiologists, who are not performing to an acceptable level. Now, I may have misunderstood you, but that seemed to be what you're saying. Now, if that's the case, in this day and age, that's a regulatory issue. We need to do something.
Yes, what I mean is that we're all aware that there are people who are the go-to people in centres and there are people who are not the go-to people. They may be within the 95% confidence intervals, and the syntax bubble slide that shows the sort of variation in performance between centres is quite extreme, if you've seen it.
I felt something should have been done about that.
Any other questions? Got a couple of minutes left, so please. This is meant to be interactive, so Adrian, another question. Good, thank you.
Disappointingly, I'm going to agree with David this time. I don't think you can say that appropriately about patients, that you decide what information they should have. I think that's completely inappropriate, personally. I think you have to allow patients the information that is necessary to come to an informed decision. You can't say patients want to decide such and such and such based on the information that is going to get them home only early. You have to allow patients to have all of the information. You have to tell them that PCI is short-term fix and stuff. I don't think that's appropriate at all.
No, of course, you can but the conversation is usually led by the patient, isn't it? You know, you say there are these two options. I mean, are you talking about the trial situation or the non-trial situation?
Every clinical situation.
Okay, so you give them a broad overview of both options, and then you allow them to lead the discussion from there on.
But you guide them in an appropriate situation about the endpoints of the treatment that you're proposing, don't you?
Yes, depending what they ask about. You know, a lot of people make decisions in an irrational way. They'll say, my uncle had a bypass and he was never the same after, and so I'm not having one.
Isn't it then your job to inform them that that's an irrational way of coming to that decision?
But you will accept that people... It is not our role necessarily to force people to change their belief, and it's often very difficult. If you do try and spend a long time persuading somebody, I think our role is just to give them the information and let them decide, not to try and persuade them that they should have one or the other.
The information is incredibly difficult to synthesize, though. It's taken the guidelines writing group years to go through that. So I think it is our job to synthesize information for a patient in the outpatient.
It's not easy. Adrian, Amal's got a question at the front here.
I've got two questions. First of all, isn't the survival advantage part of the basic information that you give a patient, that, for instance, PCI carries a low risk, good results, but surgery has equally good results, but carries a survival advantage? And the second question I got for the panel is, going back to one of Professor's slides where from the study in St George's, where the proportion of patients actually discussed by the heart team was quite low. How does the panel suggest that we address that and make those levels of discussion higher?
I think we should point out that the heart team is coming up later on this morning, and syntax is going to be discussed in detail as well later in the day. And this first session is really on the guidelines. So those questions will be answered later in the day. I've got one question for David, actually, about the guidelines and the coal face. The treatment for patients with ischemic heart disease in the guidelines is basically determined by the acuteness of the presentation and the complexity of the coronary anatomy. And the major decisions on that in terms of complexity of the anatomy is based on the syntax score. But at the coal face, are syntax scores now being calculated regularly and recorded in notes? Because certainly at our centre, they aren't. And in that discussion of how do we implement guidelines in day-to-day practice, do you think the syntax score should be calculated more regularly?
I think if you're going to make rational decisions, you need to. And I think one of the ways you can start changing it is that at every MDT, when the cardiologist shows an angiogram, you say, what's the syntax score? Because that begins to grate in them that they say, I guess it's... So I think you just have to keep raising the issue. But let me ask the audience here then, is there anyone here who routinely gets a syntax score along with a Euroscore on their patients? Anyone at all? Well, I think that's
why I asked that's why I asked the question.
That's the answer.
Well, what do the cardiologists feel? Because although a lot's based in the trials on the syntax score, it's actually quite complex and time-consuming to calculate. So in practice, we're talking about coal face. What do the cardiologists feel?
I think that's a very important question. And the answer is we don't do it routinely. And I think one of the great values of the syntax trial was that it did bring up, for sort of practical usage, a score, not a risk score, but a score of the extent of disease. In other words, I look at an angiogram and think, well, I could put two stents in the circ. That's a bifurcation, so that would be a little bit more complex, and then reopen the right. That's a lot of work. That's 5-6 stents, and that to me is a surrogate of the syntax score. And you have to do these sort of somewhat off the top of your head type calculations when a patient comes in, for instance, with an inferior infarct. I'm opening up the right. I've seen there's a lot of disease in the left that probably is best going to be managed surgically. So maybe a bare metal stent goes in the right. But you have to do these calculations off the top of your head quite quickly. But I think a reasonable surrogate is how many stents do you think will sort this patient out? And if it's probably more than 5, then that patient, is going to sort of veer towards surgery. And I've got a slide I'll show later which illustrates that.
Yeah, I would say something slightly different, which I know I've said before, but I think the syntax score is only relevant to the syntax trial. You know, it's relevant to the procedures, both surgical and cardiological, that were done in that trial. So the actual score itself, you know, saying 22 to 33 or whatever, will be completely different in a few years' time. The cut-off points will be very different. So although the score itself can be quite helpful in giving an overall idea of the complexity of the coronary disease, the idea of these cut-off points, I think, is something which is going to have to be much more fluid in the future. We will see, for example, from Excel and Noble, probably, that the cut-offs are quite different with different stents. So that's one of the reasons, apart from the time-consuming nature, that I think it's not routinely done as a kind of, here we are, it's a demarcation point, it's 33, so it has to be surgery.
Thank you very much. Ladies and gentlemen, we've run a little bit late. Thank you very much for your attention. There's coffee for 5 minutes, so back here in 5 minutes. Can we give our thanks to the two speakers, in particular, I think, the two cardiologists who brave coming to sit in front of us.